Hi, I'm Barry Childs. I'm an actuary. I'm the CEO of Lighthouse Actuarial Consulting and CareGauge. I was asked to speak at this HASA 2013 conference on how we could expand medical scheme coverage to 30% of the population, which is an interesting topic because it's not really in the policy direction that we're following at the moment. But when I thought about the question, I thought that it's an interesting question because if we turn it around, we can ask the question, well, how can we use the private sector and the assets within the private sector to alleviate the heavy burden on the public sector, and is there a way we can find a middle ground there? So I did some thinking and I did some research, and I came up with three things, that if we could do these three things, we could both increase membership within the private sector and at the same time alleviate the burden on the public sector. Those three things are, we need to finish the medical scheme regulatory reform pathway that we started 20 years ago. In the late 90s, we realized that the medical scheme environment wasn't doing what it should be doing in terms of social solidarity, and so the Medical Schemes Act of 1998 was introduced with effect from 2000, where we had the important social protection mechanisms of open enrollment, community rating, and prescribed minimum benefits. This was part of a reform pathway that was spoken about right from the Taylor Commission right through to the Ministerial Task Team on Social Health Insurance in 2005, and was intended to be followed by reforms that include risk equalization, mandatory membership, and various other changes to the way that funds were pooled and collected. Unfortunately, we got stuck on that medical scheme pathway when we got to 2007, and the policy direction changed significantly from that pathway to one of jumping straight into national health insurance. The reason that happened is that from a political and practical and social solidarity perspective, it was critical that we address the needs of those most in need as quickly as possible. And all of that is true, and that path to universal coverage is critically important to achieve. However, I think that both paths can be pursued simultaneously. I think that if we pursue if we finish medical scheme regulatory reform, if we just put in mandatory cover, for instance, which was one of the key reforms that we had planned, it would bring down the cost of medical scheme coverage. If we can do two more things, which is eliminate fraud, which we need to collaborate as an industry on, and if we can buy smarter healthcare, we could conceivably bring the cost of medical scheme contributions down by anywhere from 20 to 30%. The next thing we need to do is not give that money back. I know that sounds strange, but we need to not pocket that money. What we need to do is take that money, that 20 to 30%, and use it to income cross-subsidize the next tier of potential medical scheme people. People earning over 7,500 or 7,000 rand a month in terms of income. These people could conceivably belong to medical schemes and use private healthcare if they were income cross-subsidized, if they had some extra money coming in, a subsidy of sorts. And what I'm suggesting is the source of that money is the efficiency we could get out of the medical scheme system. We could use that money to income cross-subsidize the next tier, not in terms of a LIMS benefit package, low-income medical schemes that were spoken about up to 2006, normal medical scheme coverage with prescribed minimum benefits, etc. We just need greater income cross-subsidy. If we can do that, plus buy smarter, what we'll have done is increase the medical scheme population pool from 17% to about 30%. And the biggest benefit there, the strongest benefit, is that we dramatically increase the public sector budget per capita. We would increase it by about 20%. In other words, without doing any reforms in the public sector, we would have increased the amount of money they can spend on healthcare per person by 20%. So that means more medicines, better furnished facilities, more healthcare providers that they could afford per capita, because we've managed to take off some of that burden into the private sector. So for me, it's not one regulatory path or the other. I think that both of them can be pursued at the same time. We can't have medical schemes as a regulatory orphan. It's driving up costs, and schemes are getting anti-selected against. Costs are going up all the time. We need to coherently reform the system, both public and private, in a way that gets us to that universal coverage point the fastest, in the most equitable and efficient way possible. Thank you.